Good day, everybody. I'm Ken Capron from MemoryWorks. How are you today? We're here with this episode of Dugan's Digest, trying to bring awareness to you folks, seniors especially, and those folks who are suffering with some sort of a memory impairment in general. But we've got a website, memoryworks.org. We've got a blog on Bangor Daily News called The Journey Through Dementia. We also are very involved with the My Generations publication put out by Current Publishing of Westbrook. And that's coming out. The April edition will be out at the end of the month, and we'll have a good article in there talking about the 90-plus study that came to Maine at the beginning of April. And of course, we're doing this show, and we're looking at a possible documentary, and we're looking at a whole bunch of things through what we call the Dementia Care Coalition of Southern Maine, which is a group of people who have come together to help give a bigger voice to people with dementia, not just in Southern Maine, but statewide. And stay tuned. There's some interesting things we're going to work on in that respect. But today, I got to tell you, I'm somewhat stymied by a concept that was introduced to me very casually at first, and I sort of ignored it. Somebody had mentioned PACE to me, and I thought, okay, PACE, what is PACE? And I went and I looked it up on the internet, and I found this thing called Programs of All-Inclusive Care for the Elderly. And I'd never heard of this. And so I kind of put it aside for a while, and I thought, well, somebody must know about this. And for whatever reason, I ran into this gentleman, Brett Seekins, from my old stomping ground, Baker, Newman, Illinois, and he seemed to know all about it. And he's been working on it for a long time. So let me just give you a brief bio on Brett. Brett's a senior manager with Baker, Newman, Illinois, which is a firm which provides professional services, has offices in Portland, Manchester, Portsmouth, and Boston. Brett works in the Healthcare Management Services Department with the firm, and Brett's been involved in a lot of the healthcare issues and now some of the senior issues around the state. And I think Brett's done a few cost reports and a few of those other things that we all hate to do, and a statistical analysis and what have you. But Brett, welcome to Dugan's Digest.
Thank you for having me today, Ken. And as you said, PACE, the PACE program, I have been working on that for a number of years. I'm a former reimbursement administrator and Medicare auditor. I worked for HCFA, the old Healthcare Finance Administration.
Oh, you're kidding.
Back in the 90s. And the PACE program first came across my desk as I was taking a look at some Federal Register updates. And as you mentioned in the name, it's the all-inclusive care program for the elderly. So what's that mean? Everything's included. To be a member in the PACE program, you need to be 55, nursing home eligible, and capable of living at home safely, which is what everyone wants to do today.
Wait a minute.
Seems like you'd be a good fit in Maine.
Wait a minute. Nursing home eligible, but capable of living home.
Yes.
That seemed to be a contradictory.
It does, and what the PACE program does is all those services that you would have in this real expensive setting over here. Remember, part of the Affordable Care Act, although PACE has actually been around since 1972.
1972?
But, yes, but if we're going to reduce cost from these expensive institutions, if we can find some people that are capable, even though they're nursing home eligible, of living at home, and we can bring supports and services to the house, and whatever supports and services we can't conduct in the home, we provide transportation to pick that person up, to bring them over to something we call a PACE center, where the services are at the PACE center. And when they're done with their treatment or their therapy, or maybe perhaps they just went there for a social activity in the adult health center, we bring them home. And we'll bring them meals. And we'll help them with their activities of independent living. Everything's
ADLs.
included in this program, from personal care services to acute hospital stays. Yeah.
I got to, no,
mind-boggling, isn't it?
72, this program came into existence.
Yes, so the history comes back in 72, and it's just so interesting. So at this time, what we had out in California and the San Francisco Bay Area. There's a lot of immigrants coming over from, some of the war territories over
Right.
in Asia, and they settled in the San Francisco Bay Area as immigrants. Now, as their families are brought up, we know the children live with the parents and the grandparents and the great-great-parents. Well, when it came to healthcare in those societies, at the end of someone's life, when they needed long-term care services, it was unthinkable to them to put them away in a nursing home. The nursing homes in the early 70s were very, very new. They really didn't start up until 1965, when Medicaid and Medicare law was revised through the Social Security Act. The second revision to it. And that was kind of the beginning of nursing homes. So as it played out, these families, again, unthinkable to them that they would even, though we had nice nursing homes back then, that they would send them away there permanently to be taken care of. They wanted those services to be performed in the home. So a dentist, of all people, developed
In California?
this concept. Yes, in California, in the San Francisco Bay Area. So the idea of this was, let's perform these services that might be in an expensive setting over here in this setting. It's what the patient wants, number two, and it'll improve quality. What's that sound like? The Affordable Care Act today.
Well, I'm still lost by the fact that this has been around for what are we talking, 40 years now?
Yes.
And Maine doesn't have it.
Maine does not have it. There's about, I think, 20 states that still do not have a PACE program. So it was tested out in California for a number of years. The Centers for Medicare and Medicaid Services kind of picked up on this program. They were watching it along with the Health and Human Services Department in California. And in 1996, after a few pilots and a few demonstrations to see if it could work, to see which setting it could work best in, because you do have to have some scale in your population to kind of make this program work. They made it a permanent Medicare program in 1996.
So they didn't design it originally.
CMS, no. Or HCFA, no. It was actually this dentist, and he worked with the Department of Health and Human Services in California at the time, and the Medicaid office
So what was his beef? Why would a dentist get involved in that?
He just found it really interesting. Isn't that cool? Just, of all people, a dentist. Perhaps he knew the family that was trying to set this thing up, but that's how it started. So if a state does want to become or have PACE in their state, they just work with the federal government, the Centers for Medicare and Medicaid Services.
So it's the people who do run the Medicare and Medicaid right now who are behind this, but they're not pushing it out. Like, they're not trying to get states to adopt it. They don't seem to be in any hurry to.
Actually, the feds love PACE. And
really?
In the Affordable Care Act, that came out in March 2010, they even spoke to PACE and tried to advance it. They used to, when they were trying to push this out, had grants set up for states to try to, but those are no longer available. But they highly encourage it.
So this has been available a long time, and there was grant money that came to get it started, and Maine still didn't jump on board. Do you have any reason or any knowledge of why we didn't jump into this? This is a great program, it sounds like.
I don't know. I have been working with the last two administrations just on some advocacy and some education with some other stakeholders that think this would be an interesting demonstration in Maine. We're the oldest state in the nation. We have the highest proportion of baby boomers to total population in the country. And could this help our state out? So it does tend to work best in some of the bigger towns, so maybe Portland, Lewiston, Auburn, Bangor, Augusta, something like that, where we can build some scale. But what we did find out, there was a report that was written to the U.S. legislature by Kathleen Svalis, who was the former HHS administrator down in Washington, D.C., and they spoke very favorable of rural PACE programs. The LePage administration and Commissioner Mayhew is very, very interested in this. And me and a number of stakeholders have spoken with the commissioner several times about this, and they're just extremely interested. So we are excited about that potential. It does take a lot to kind of get the program up and running, though. So these things do tend to take some time. But
so let's go back. All-inclusive is a pretty big term. What do you mean, all-inclusive care? That's a big term.
You name it, it's included.
No.
independent activities of daily living to assistance with activities of daily living, mental health, psycho and social therapy type services, behavioral health services, folks with Alzheimer's, folks with dementia is covered. All ancillary services are covered. Podiatry, dentistry, your primary care physician. Now
Vision?
Yes, vision's covered. Everything is covered. In the hopes that if we take a look at population health, and we're going to take a look at this group of people here, if we can provide the services, preventative services, wellness services, heavily case-mixed, patient-centered care plans to keep these folks at their home, instead of being over here, and we can save money, why not do it?
I'm looking at a short list, and it also includes transportation.
Yes, it does.
So we know in Maine, transportation is a huge issue.
It is.
Even in the cities, transportation is not exactly elder-friendly.
And you know what the great thing about this, let's say we've got a husband and wife, and the husband needs to go to a lot of different appointments all the time, or perhaps there was a fall or something, and they were recovering, and they did their rehab, and then they came home. Home health services is covered in this, but there are, those daily trips back to the doctor, back to the specialist, maybe over to a lab. Well, that person or their partner would have to be coordinating all those appointments, right? No.
On the outside.
PACE program does it. One person. It alleviates that headache. It gets rid of all those administrative silos that we keep talking about.
The caregiver's job becomes easier.
Certainly.
And the patient gets better coverage.
Yes.
This is getting logical. I hate to say this, but this
It is.
For a government program, this is sounding way too logical. So providers. One of the things that providers have always been concerned about Medicaid, and anything mentioning Medicaid, is getting paid. What's the payment scenario under a PACE program?
It's really kind of interesting. If anyone can be a PACE member, and that's what they refer to their, whether consumers or clients, we call those folks different things, but they're PACE members. And just by virtue of that name, it's voluntary. So you can opt in, you can opt out. So as they become a PACE member, then we talk about payment source, because anyone can be, again, it's 3 requirements: 55 years old, nursing home eligible, capable of living in your home safely. So if you're Medicaid eligible, there is no cost to the member at all. If you're only Medicare eligible, you have to make up one side of a payment source. If you're Medicaid and Medicare eligible, no charge to the member. If you're neither Medicaid or Medicare eligible, you have to pay privately. So there is a payment to the PACE provider by Medicaid and by Medicare for those folks that are eligible. The Medicare portion, there is a base fee, and then there's something called a frailty adjustment factor. So as the PACE program is... Yes?
For frail seniors.
Nope. Let's say you have a catastrophic... Well, you're going to get a base payment. Let's say you have a catastrophic event. Well, that Medicare payment increases back to the PACE member, the PACE site, the PACE provider. The Medicaid side, so the payments are 2 sides, Medicaid plus Medicare. Medicare, adjusted frailty factor, it kind of slides up and down depending on the needs. Maybe you're not taking any medications. By the way, pharmacy is included in this. The PACE provider uses Part D, but that's all free, and it's included. I don't want to say free. Excuse me. But let's say you need a new medication. Well, that Medicare payment increases for the provider so they can purchase that medication for the member. The Medicaid side, that's a little bit more difficult to wrap your hand around, but very simply, what the states try to do is they examine, okay, what's our annual cost of taking care of someone, understanding that PACE program, it's all inclusive. What would be the cost to the Medicaid program of taking care of that person on an annual basis? And what the states do is they determine that amount through an actuarially determined or actuarially sound assessment, and then they tell the PACE provider, we'll give you 80% of that number.
Interesting.
So the state saves 20%, right off the top.
Wait a minute. This is getting too good. Come on.
That's it. And it's up to the PACE program, again, to heavily case manage, develop person-centered care plans. So we're on the phone every day, twice a day, 3 times a day, as needed. Did you take your medication? We brought you to that clinic today. How'd that go? And this constant follow-up and feedback, just so we can keep tweaking that care plan to keep them home
So
in
there's
a
a
less
care-
expensive setting.
There's a
And
case
it's where they
manager.
want to be
There's a case manager who
for every member.
navigates people through the system.
Yes.
And coordinates this and actually brings some logic to this. And I want to get back to the 55 and all that stuff, the requirements, but you're saying that the PACE Center is like a one-stop shop?
It is. Think of it just your strip mall that you pull up into. And right in the middle there, there's an adult day health center. We've got activities in there. So we've got our social connection, right? We've got our community involvement. We have people coming in and out all the time through the activities department, socializing with them. Legislators are coming in, right? So imagine all that stimulation that someone's getting in that
Yeah.
adult day health center. Or should they be staying at home? Or so it's just every person, their plan of care, the way it works is someday some people might be assigned to that adult day health center 7 days a week. Some 1, some 3, some 5. It's that person-centered and heavily case managed. Whatever they feel perhaps the person can get out and doing other activities at home, or maybe somebody's home life. Someone has to work 5 days a week in the home. So this is a great respite.
Absolutely.
For that their partner or their companion.
It gives the
or their family
caregiver
member.
respite? Well, wait a minute. This is just getting way out of hand.
Yeah.
This is way too logical and way too beneficial. Why? Well, we'll get into the why. So you have to be 55 or older. Is there any flexibility in that? I mean, if you're really sick and you're younger, you don't qualify, or if you're...
Those are federal guidelines.
Okay.
However, as you suggest that, CMS, again, Centers for Medicare and Medicaid Services, are looking to expand this concept. And why not? Because we know a lot of young adult, maybe up to young adult, like from age, from birth to age 20, there's some coverage there. But we talk about gaps in services with Medicaid and Medicare, and it's really like that, 21 to 54.
Right.
So if you're talking about that gap right there, CMS has really taken a look at the PACE program and said, this does make sense. Our members are very happy and satisfied. We're seeing great outcomes here. We're able to keep folks longer at home where they want to be in less expensive settings. Why don't we look at this gap from 20 to 54 and do something in there? So there are national studies going on to do just that. And they're also taking a look at plugging this into Veterans Administration benefits.
If you could do the calculation that you mentioned, where you sit down and you say, well, how much is this person really going to cost us right now under the existing
And they
system?
take a look at everything. Home care services, acute care services, medicine, medical supplies, all that stuff.
And if they knew that person was going to be, say, $15,000 a year, and you can cut 20% off of that,
yeah,
that's a no-brainer.
So they take kind of like that average cost of a person who wasn't in a PACE program. What's that cost? What's that average cost? And that's their starting point. And I don't know what percentage they go off, but you can just see by example, maybe it's 85%. We'll pay you 85%. Well, you save 15%.
Yeah, it's still less than 100%.
And you know what else you did? You moved all your risk over to this party.
Yeah, all your risk.
Yeah.
So what is...
This is kind of an insurance type program as well. You can kind of see the backdrop, the back office stuff. And it is heavily managed by CMS and the states. They're in there conducting audits all the time.
Oh, really?
Yep. There's federal money involved, and we've also got people that they're partnering with in the community coming in and out of contact with their PACE members.
Now, are you saying that the states and the Fed are running the programs, or just auditing the programs?
They're auditing and oversight.
Okay, so it's still privately run center
by a nonprofit.
By
yes.
a nonprofit.
You have to be a nonprofit.
So you're not there to make money. You're there to break even and provide the services and
typically you're gonna net 3 to 5%.
Yep.
It's not set up for this big, moneymaker windfall thing. And we wouldn't want that because you're not putting the money where it should be. And if you were trying to make 20% off this thing, these people are going to be landing in the hospital. That's why the oversight's necessary. They're going to be in these places that they shouldn't be.
So,
CMS has got it worked out.
so one of the big requirements here is it says you have to be at a point of needing a nursing home level of care. Who defines what is a nursing home level of care?
Well, each state does.
Oh, it's different based on the state's definition.
Yes, it is. And Maine, in fact, has one of the highest eligibility criteria for nursing homes in the country.
What does that mean? I mean,
It's harder to get into nursing homes.
you have to be missing 2 legs and 2 arms?
Well, they take a look at one's activities of daily living, which is, a measure of different bodily functions and, cognitive abilities and the number of medications you're on, and also a socioeconomic type background. And,
Oh, really?
There's so many factors that go into determining whether you're nursing home eligible. But basically, they take a look at activities of daily living and how well are you able to manage yourself during your day.
So, I mean, are some of the states are fairly lenient about those guidelines, or how does it differ as to between states?
Some states, there's basically 7 or 8 activities of daily living. Some states will only look at 5. Some states will say, if you need help with 2 of the 5, you're eligible for nursing home. Some states say, well, I think that number should be 3 out of 5, or maybe some states use 7. So we're talking about eating, bathing, transferring, personal hygiene, toilet use, and just, a number of those types of things. How much help do you need with that? And there's a scoring system. Do you need limited help? Do you need no help? Or do you really need a lot of help? Mm-hmm. So Maine just happens to be, that bar.
Now, who makes that determination as to low, medium, or high levels of help? And
that criteria has been established for a long time. I believe it's by the department.
okay. I'm just wondering if it's like the current system. There's this evaluation that's done by, what's the company? Gould.
Yes. They would use those tools that I spoke to.
But in Maine, the problem with that is that in order to get a Gould assessment, you have to be in a nursing home. In order to get into a nursing home, you have to have a Gould assessment. So there's this really weird
circular
thinking.
The other thing is Maine does have a benefit for a residential care bed, which is under a private non-medical institute classification, and think of it as a step-down unit to a nursing home. These folks do need some help. There's a lot of referrals from different offices around the state for folks, maybe they're just not in a safe environment at home, and they do need a lot of assistance, but not nursing home level. There is this residential care benefit that Medicaid does participate in for roughly 3,100 folks in the state. So maybe our nursing home eligibility criteria is set so high because we have this buffer right here. That
was reduced recently, right? It was more than 3,100 recently.
Well, there's 4,200 beds. 31 are occupied by Medicaid residents. 3,100 are occupied. So about 75% of the 4,100 beds are operated folks with Medicaid. Under Medicaid.
So I'm still trying to wrap my head around. So the people who are nursing home ready, they're whatever activities of daily living are not working for them, kind of determines whether they qualify for PACE. What if you've only got 2, but you need 3 to qualify? I mean, are those folks just left out until they lose another function?
Yes, they are.
Okay.
So they'd be searching for another program to perhaps assist them with those 2 ADLs.
So at some point, we need to, I need to find out, at least for the audience, what the state's requirement is on that. What exactly are they looking for, and can we change that?
The rules are strict, for a reason. We do have to accept that, because then you're picking and choosing, and that gets sloppy. So,
yeah.
It's set up by the federal government. We have to respect and honor that, and the way the state is set up. Again, the nursing home eligibility criteria, which goes back, I think, to 1994 or something like that. So certainly the past few administrations had nothing to do with setting this bar. We did have a creation of this other program to help folks out. So it's there for a reason. It's served its purpose, but it's being talked about.
Yeah.
And it is on the state's website that's part of a discussion going forward.
What I am hearing a lot from the various facilities is that the people that are coming in are sicker than they used to be.
Yes, they are.
People entering the nursing home or the assisted living are worse now than they used to be maybe a couple decades ago. So,
And really not knowing anything about healthcare, just anecdotally, you can kind of figure that out, because what's our experience in the acute care system? Well, everyone kind of thinks, okay, we're getting out a lot quicker now. You know, back in the 70s or 80s, we might have been in there 5 or 10 days for whatever event it is, and now just the way the system has evolved, we're out of the hospital quicker, over in these other settings, getting assistance if we need it. But just anecdotally thinking through that example, well, then the people are sicker that are coming out. And we may discharge out of the hospital earlier because we've had advances in nursing home care as well.
I'm just wondering if some of that relates to the fact that we're trying to keep people at home longer through the aging in place process. And so we don't put them into a program like this until they are pretty far along anyway. I don't know, are we waiting till things get more extreme before we put them into the more advanced settings, the assisted living and in this case, a PACE?
Well, you know, if we had PACE, it just might work out here.
Yeah.
You know, if we could plug that in, do a demonstration, test it somewhere. Right now, maybe your point was where folks are sicker. How could we bring this program in Maine where the eligibility criteria so high? How can we keep that person at home? Excellent point.
How do we set the bar a little bit lower so that more, you know, that...
So that's the thought. And I think before you're going to ask me, you know, how come we're not doing this in Maine? Why? That's a bit of a problem. And you can tell that takes a lot of thinking, a lot of governance to move that down, the eligibility criteria down, and a lot of planning at the government level through the commissioner's office with, you know, staff. And then there's this huge stakeholder community. Maine's a big ship, and it takes a little while to turn this thing around. To plug PACE in, that involves DHS, that involves the Bureau of Insurance, and probably 10 other organizations.
Within the state?
Yes, you know, to tee that up and get that moving. So it's a big ship.
So who are the big players who might be behind this here in Maine? Has AARP pushed this? Has you know, any of the big agencies on aging or the hospitals, or has anybody been pushing this concept forward?
Well, I know the Volunteers of America Northern New England group has been very vocal about PACE. I had been working with them the last 4 or 5 years just on advocacy and education, working with the department to let them know about the program. The National PACE organization vice president has been up to Maine 4 or 5 times talking with the administration.
There's a national PACE organization?
Yes, there is, NPAonline.org.
So this is big enough that they have their own national organization that people actually pay dues to, and have some help with keeping the Congress in line on funding and stuff.
I think we're closing in on 200 PACE sites nationally in over 30 states.
And have you been to any PACE sites?
Yes, I have. I went down to a PACE site in Massachusetts and took a tour.
Tell me what your thoughts were.
It's pretty amazing.
Really?
There are a lot of things going on.
Is it a big? Did somebody just plant this big building in the middle of some acreage and?
That's certainly what it looked like.
Oh, okay.
It was. That's certainly what it looked like. It was a large building, because every PACE site can be a little bit different. I asked you to envision a strip mall, because essentially that's what it is. Whether that's 5 stories or just one flat, story. One flat long one. But yeah, we walked in, just all kinds of people, all kinds of activities. Very, very robust and the staff was just so friendly, because things are just so mobile and fluid, just so many things going on at once, and you just see the social interaction of the members working with different staff members who are involved in an activity, or they keep those folks busy and entertained.
One of the things that I find here in Maine is that when you build, for example, an adult daycare, it sort of services the same people who are also doing all the other things. So a select group of people get involved in the activities and the socialization and stuff, but it's always the same people. So I'm just curious, what I would like to see a PACE do is to reach out to people who haven't yet joined the system and aren't getting the daily stimulation from socialization and aren't getting even medical care. I see that a lot at the memory cafes, people who are just don't trust the healthcare system, and so they haven't gone to a doctor yet, or they don't trust what the doctor has said, or that's the main way. People don't necessarily trust their
There is some fierce
doctor.
independence out there.
There is.
You might recall I'm the chairman of the Cape Elizabeth Senior Citizen Advisory Commission, and yeah, we do see that. We've heard those comments. There's folks that genuinely need help, but they are some a bit stubborn, some fiercely independent, just won't make that call. So we have to find those people, and we have to work with them to get them some help, because they can only do that for so long, and then they're going to present, and then we've got some issues. That were preventable. And not to mention that the isolation, which I think is what you're getting back to.
Well, I think, that's probably the worst thing that you can do for any senior, regardless of whether they have dementia or not. Isolation is a killer. And
Number one.
Even if you just join one group a month and go out and have maybe lunch with them or something, once a month is an improvement. But regular participation in activities, from the 90+ study that I've mentioned in the past, that socialization was as critical a factor as having the right kind of medical treatments and stuff like that. So socialization is as strong a medication as anything else. Okay, so I've avoided the question, but why the heck don't we have this in Maine? It sounds just too good to be true.
It is. I think there's a lot of careful study right now. We've been working with a few different administrations, and it sounds like it's simple. Let's just have a PACE program.
Yeah.
But it involves so many other offices, and I can just imagine that there's a lot of other perhaps competing programs that are hitting the state now, and it just takes a while. It just does.
It sounds like, especially, it beat the Affordable Care Act by decades, and yet it's not as well adopted.
Yeah. Certainly room for growth.
Yeah, and I guess, any idea, have you talked to the National PACE organization and other PACEs to find out what the initial startup costs are, and what are the chances that it will pay for itself?
That's an interesting question. What do you think it is, startup costs?
Startup costs? I'm going to say $5 million.
Yeah, it is. It's right around there. You're a good accountant. I was around 3, and I was told you should think about doubling that, and it probably takes 3 to 5 years to start seeing any return come back.
And do most PACEs start by building a building, or do they acquire a building, or where is the route?
So you really have to be an efficient and effective manager if you're going to be a PACE provider. So, and let me go back a little bit. So if the state were to adopt PACE, and we're going to make this a permanent program, or even a demonstration in the state, what they would do is send out a request for proposal to interested parties to become a PACE provider in this area.
So they go out for like an RFP.
Yes, for a set of zip codes. So let's just say Greater Portland, whatever towns are in Greater Portland. So what that means, or prevents from doing, let's say Ken is awarded the contract and you're a PACE provider in these set of zip codes. Brett can't come in and set up a PACE site right next to yours. So typically competition, we think of competition, well, that's healthy, that's good, that drives down prices. It does not work like this. You have to have one, because that PACE provider is really trying to find 200 members.
Oh, really? So there's
That's about the max.
Optimum number.
150 to 200 members.
Oh, wow, that's intriguing.
That's about perfect. Now, if we've got Ken's PACE site, you're the PACE provider. If you want to open up a satellite over here, you can do that. But you have to work with the state and see.
But it has to be in the same zip codes?
Yes.
Okay, so you're always stuck within that.
Or get permission to be there. Yeah, have an extension, have a satellite.
Sounds like the gold off the coast of Alaska, where they have plots that you can lease the right to dig gold in that spot.
And so maybe you can see, what if we had one of these in Augusta? Okay, that's pretty central. Now we can have satellites over here in the rural pockets, although Augusta is still considered rural as well, even though it's a pretty big state and the capital. It is in Kennebec, and Kennebec is considered a rural county.
So this obviously doesn't produce a financial windfall for anybody, because it really is a nonprofit organization, and it's not going to pay its members some exorbitant amount. You're not going to have a $500,000 doctor involved in there. You're going to have much more reasonable care levels, managed care. People will be looking after you all the time to make sure you're getting the right, and not too much, not too little.
That's correct. So to get back to, so I kind of teed up the real answer. I was like, how do we do this thing? As I was saying, you have to be very effective and efficient manager. You were wondering, do they have to build your own building, or do you lease one? You can do either, what kind of makes sense, but as you know now, you're not going to be rich and profit, so we have to, is there an existing building that we can lease? And as you mentioned, we're going to hire our doctors. So here's the deal. Let's try to find that leased building. You know where it is. It's going to fit your program. And then all the things that PACE covers, whether it's home care, personal care services, all those doctors and specialists and ancillary services, all the therapies that we mentioned, we're going to contract with people out in the community. Mm-hmm. So I'm not building all these bricks and mortar, type things in silos, all the administrative burden that comes along with, because I don't have the money. So we're going to partner with existing people with great reputations out in the community to provide those services. I might not have an adult day health center in my PACE site.
Gotcha.
But you do, so I'm going to call Ken up. Hey, Ken, I've got some members, and so I'm going to fill up your adult day health center. You have to partner with the existing folks out in the community. And as you apply to become a PACE provider, you actually have to submit those contracts or intent to contract with different partners to provide these types of services that a PACE program would provide. And you have to have a signed intent to contract as well.
So on the ground floor, what would we need to do, for example, right now to go and move this to the next step or get this further considered? Are we waiting for the sky to fall, or what's the next step?
No, I believe the state has quietly been pushing this along to the various channels that need to be involved. Right now, the Bureau of Insurance is taking a look at some paperwork and some numbers to see if it works. And, timing's everything. Obviously, we're involved in a very busy legislative session right now. Resources are a little tight in the state, as we all know, and it just takes time. So we're just being patient.
Should I tell people if you're listening, to contact your legislator and ask them to inquire about PACE, or should we go and be talking to the legislator? I don't want to lobby this. It doesn't sound like a political entity.
Well, we do know that the department is working on it.
Yeah.
And it just does take a little bit of time. If this is a program that folks are interested in, certainly those offices are available to call and say, geez, I'd like to learn more about this. Every time I've contacted the department, they've been very, very helpful.
Well, Brett, as you know, we've got a meeting with Mary Mayhew on the 27th. And I'll be interested. I'll bring this one up and see if we can't find out where it is and help move it to the next step. If it's money or people or whatever, let's try to work on moving it forward, because it sounds too good to be true.
She and her staff have been absolutely terrific. Anytime a call from either myself or the constituents or stakeholders I've worked with have called her or her staff, they have made themselves available.
What happens if the wrong person gets the zip codes? Not everybody is well-intentioned, and I think, didn't one of the PACE units fail in Vermont?
Yeah, they did.
Poorly run or something?
Just a system of problems that occurred, and I think some changeover with staff and management and perhaps expectations. Fill ratio of this thing is very, very important. Vermont is a rural state by all intents and purposes, at least for as the federal government and CMS identifies Vermont. So that was kind of a maybe perhaps a tricky play to begin with.
So if a PACE itself handles about 200 people as patients, is it scalable? Is there a way to make it so that it can handle 1,000 seniors? Or, I mean, there seems to be a lot more than 200 people in Portland who could use this type of service.
So the folks that I went and visited down in Portland, Massachusetts, they're on the North Shore.
Yeah.
They have their PACE site right there, and they have 6 satellites,
Oh,
and they have over 900 members.
through satellites.
So it is scalable. But, you know, the point is you wouldn't want to build this structure where you have 1,000 folks that could potentially be, that's too big, right? Operationally, it doesn't make sense to have 1,000 people that are nursing home eligible in this space. So by design and intent, we're going to keep it a bit smaller and then build out if you have the scale. So I think that's smart. It's safe, right? We're going to keep that
Smart and safe.
structure safe.
Is that going to be, is smart and safe going to be get us where we need to be with the silver tsunami and this horde of seniors who are coming down the pike, so to say?
Well, I think we have to intelligently put in these programs and smart and safe. I mean, if my parents are going to, you know, a PACE site, I certainly would want those 2 words in the conversation.
Oh, excellent.
Looks good on paper. Plug it in, huh?
And
thinking a little more.
And there's nobody in the background right now who's saying, you know, if we can get this built or get this approved, I'll build one tomorrow. There's no funders stepping up saying they want to get this started.
I've heard that there are some folks that have contacted the state privately and let them know that they are interested, and I've heard as many as 5 or 6 big players that are interested in this program.
But they're not being very public about that desire
No.
yet.
No, it's been private, just having private discussions.
Cool. I think we've pretty much covered most of the PACE. I did want to just ask a question, that is, if I live in New Hampshire, and which doesn't have a PACE, and I move to Massachusetts tomorrow because they have a PACE, am I immediately eligible to be part of the Massachusetts, one of the PACEs in Massachusetts? If I'm nursing home eligible and I'm 55?
All those 3 things. I understand the example, you know, state by state. I would think yes.
I mean, is this a way to attract more seniors to Maine? Or retain seniors? Or it would certainly create jobs, I would assume.
Yes, we could create jobs. Perhaps it would keep some seniors here. But, you know, trans-migratory or folks moving in just to all of a sudden, I don't know, that's a complex question.
It is.
There's some eligibility criteria involved in occupancy, you know, how long have you lived in the state, and, you know, eligible type requirements.
Well, I go back to something that Charlie Colgan, the state economics guru for the past 10 years or so, he said very early on in a lot of the discussions around aging that if we could do it right here in Maine, we could become a destination rather than a departure point for seniors, because we should, with the largest percentage of people over 65, we should be able to do it well if we do it right, and attract people here, make it so that people want to come here for the care.
Interesting. I had heard in my commission someone speaking to us recently about the Florida effect, and apparently, you know, the building boom is back, and developers are coming in, raising 1,000 acres, putting up all kinds of homes just for seniors, and they're coming in from everywhere. So perhaps, yes, you're not far-fetched at all thinking this could be a destination.
Yeah, I'm just not sure exactly how all that works, because there's politics and there's money and there's a very independent population, and I'm just not sure how we change the status quo.
It's some private solutions, folks taking a peek and going, you know, this is a good fit here. And then, of course, public and government solutions, they all have to work together.
Thank you for watching this episode, and Brett, thank you very much for your wisdom. You are indeed the guru of PACE.
Wow.
in my opinion. And if there is somebody who knows more, let me know. I'll put them on, and we'll do a comparison tape. But really learned a lot, and I do encourage those of you who are watching this, feel free to reach out to your legislator and ask them to, tell them you want a PACE. There's no harm in having one that I can see, and it sounds like it's good all around. But this is your chance to help you, your family, friends, neighbors, your aunts, uncles, grandparents, whatever. Have a better future here in Maine for your care. And it truly is 100% care. I mean, they really do. It's amazing all the things that are listed. And so I encourage you to do that. I'm Ken Capron, and this is Dugan's Digest. And we'll be back, I think the next show, we're planning on having Natalie Deschanel of Coastal Rehab talk about PTOT, not Oprah therapy, not Phil therapy, physical therapy, occupational therapy, speech therapy, and what's happening in that industry here in southern Maine. Thank you, and we'll be back.